So was it last year? I can't remember when I asked Dr. Trescot
last year
to make this presentation because, as I mentioned earlier, we're not looking at blood test results the way we should be. So a lot of times after brain injury, people will have really low vitamin counts, like vitamin D will be through the floor. But also when it comes to hormones, people are not double checking things before they're prescribing. And so one example from somebody that I won't disclose because I never got permission to share their name, they talked about how so they're in behavioral health kind of counseling therapy fields, and they got a referral from a medical provider saying, I'd like you to verify depression before we prescribe. And as they talked with the patient, they realized this is not depression, this might be thyroid. And they said, can you get your thyroid checked? And the patient was like, yeah, sure. And it turns out they had severe hypothyroidism. But if you went down a check mark box and just checked the boxes, it would look like depression. They fit the different symptoms, but there was more going on. And it took the behavioral health specialist to dig deeper to realize they didn't need an antidepressant. They needed their thyroid to be treated. And this was outside of Alaska. Now, in Alaska, more often than not, it goes the other direction. The doctor says, here's the antidepressant, and here's the referral for counseling. And so by the time someone gets to the counselor, they might be having a really bad reaction to the medication. And now the counselor has twice the work, double the job to try to figure out what's going on. And so I just think this is so important in terms of baseline testing and in terms of understanding what's happening in your own body. And I'm just so thankful that Dr. Trescot was willing to do this and is going to be available for questions after. And I hope you get nice, wonderful sleep after we're all done.
I tell you, it has been, I have been in so many, since the 30th, I was in Indonesia, Singapore, and South Korea in February, and then back in Alaska, and then back down California, Houston, and now Florida just got in. So it's the last of my traveling for quite a while.
Right. So you definitely tick all the boxes for quarantining.
Listen, I have to, I am now in the middle of, I am in a house that has had nobody in it in 3 months. And I am locked away in here. I got all the groceries done this morning. And after I left, I went from the airport to the grocery store, loaded up on groceries, and trying to get everything done before we go into quarantine, before we go into lockdown tomorrow.
Yeah. I sorry, not sorry. That's what happens when you're the best. Everybody wants you. So I am gonna hit the from the beginning. Once again, let me know if you cannot hear it. Otherwise, let's do it.
Hello, my name is Andrea Trescot, and I'm going to talk today about the diagnostic test for traumatic brain injury. I am currently the medical director of the Pain and Headache Center in Eagle River in Soldotna, an affiliate assistant professor at the WWAMI School of Medicine, and a former professor at the University of Washington. I'm also the chief medical officer of a company called StimWave, which has nothing to do with this lecture. So, there were about 2.8 million visits to the emergency room for traumatic brain injuries in 2013. We know men have a higher incidence of TBI than women and a higher death rate than women. And that may be because men may have secondarily a greater prevalence of being involved in high-risk activities such as contact sports and the military. It's those contact or competitive sports such as boxing, kickboxing, football, soccer, rugby, and ice hockey that are the most common sports that can lead to chronic and repetitive TBI. And these consequences result in personality disorders in about 33% of patients, survivors of severe TBI. About 25% have major depressive disorders, 15% have anxiety disorders, and nearly 10% have alcohol dependence, all of which significantly impact the quality of life and work capacity. Those long-term cognitive impairments are also highly prevalent, seen in more than 50% of the patients who survive a severe TBI. There's also some common TBI findings such as lethargy, fatigue, and slowed mental processing time. But those are also symptoms of associated neuroendocrine complications. And so it's the knowledge of that potential blood work to look at the neuroendocrine complications and a high index of suspicion that are necessary to identify and treat the consequences of TBI. Now, you can have primary and secondary brain injuries. The primary injury is the initial actual physical insult, and that results in compression and shearing of adjacent tissues with or without a loss of consciousness. Secondary injury is a very complex process, though, that occurs in the hours and days following the primary injury, and that can have both cranial and systemic complications. The cranial complications can include cerebral edema, intracranial hypertension, infection, calcium ion toxicity, and vasospasm. While the systemic complications are mainly ischemic or a lack of blood flow, and they include hypoxia or a lack of oxygen, hypotension, which is low blood pressure, hypertension, which is high blood pressure, hyperglycemia or high blood sugar, and hypoglycemia. So why do we need to test? Well, because as I said, there's a significant occurrence of these pituitary dysfunctions after TBI, and it ranges from 15 to 50%. And by identifying them, we can potentially treat them. Now, this is not a new understanding. Pituitary dysfunction in TBI was actually described in 1918 with partial or complete low pituitarism as a potential consequence. It's felt to be due to either hypoxic insult, the lack of oxygen, or direct mechanical injury to the hypothalamus, the pituitary stalk, or the gland itself. There could also be compression from hemorrhage, edema or increased intracranial pressure, or vascular injury to the hypothalamus or the pituitary. So this pituitary gland sits at the very base of the skull in a little depression in the base of the skull called the sella turcica, which means Turkish saddle. And the pituitary is made up of an anterior lobe and a posterior lobe, and they're connected by a stalk to the hypothalamus. And there's blood flow to each that is separate, so you can have effects to the anterior or the pituitary or both, as well as to the hypothalamus. So the anterior pituitary hormones include growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, and prolactin, while the posterior pituitary hormones include antidiuretic hormone and oxytocin. So in the first 24 hours after TBI, about 20 to 30% of patients were reported to have abnormalities in growth hormone and insulin-like growth hormone factor concentrations. And studies have suggested high rates, as much as 50 to 75%, of hypothalamus, pituitary, and adrenal axis dysfunction within the first 10 days of injury. Pituitary dysfunction may manifest as an insidious onset weeks to months after the original closed-head injury, and it can show up as progressive lethargy, anorexia or a lack of appetite, hypothermia, which is low temperature, bradycardia, which is low heart rate, or hypotension with hyponatremia or low sodium. So any unexplained onset of malaise and generally decreased vital signs with an associated stagnation of the rehabilitation process in a patient following a closed-head injury should prompt the clinician to suspect the presence of a pituitary dysfunction. And blast injuries are a particular risk factor. Turns out that 32% of soldiers after a moderately severe blast injury developed anterior pituitary dysfunction, compared to only 2.6% of the age-matched and gender-matched civilians after the same moderate to severe TBI that was not blast-related. Growth hormone deficiency is the most common anterior pituitary deficiency associated with TBI, and it can be seen 15 to 50% of severe TBI patients. And the risk is still 10 to 30% a year after a moderate TBI. These symptoms include increased cardiovascular risk because of elevated lipids and high-density cholesterol, growth retardation because of this growth hormone deficiency if the TBI is in a child, memory and concentration impairments, anxiety and depression, social isolation, weight gain, osteoporosis, and exercise intolerance. The thyroid stimulating hormone is the second most common anterior pituitary deficiency in TBI. And this presents as a low T4 without an appropriate increase in TSH. And so a year after a moderate TBI, you can still have a risk of TSH deficiency that's 2 to 3%. These symptoms include fatigue, increased sensitivity to cold, constipation, dry skin, weight gain, hoarseness, muscle weakness, and depression. There can also be adrenocorticotropic hormone deficiency, and this is seen with a serum cortisol less than 36, which is considered, quote, strongly suggestive, end quote, of an adrenal insufficiency if the ACTH is not elevated. Because cortisol and ACTH, and actually all of these enzymes, should be in a reciprocal relationship. If one goes up, the other goes down, sort of in a seesaw fashion. So if the cortisol goes down, the ACTH should go up. And if it doesn't go up, that suggests there's a problem with the release of ACTH. And 1 year after a moderate TBI, the risk of ACTH deficiency was 5 to 10%. These symptoms will include weight loss, anorexia, fatigue, muscle weakness, nausea and vomiting, hypotension, and depression. So you really ought to be screening for ACTH and cortisol levels when when you've got symptoms of a suspected depression that it has a severe general fatigue and an appetite loss, especially if it's associated with vomiting. There's also antidiuretic hormone, which is coming from the posterior pituitary. And this results in diabetes insipidus, a massive diarrhea that has very little in the way of electrolytes with it. So it leads to tremendous amounts of fluid loss. This is associated with severe TBIs as well as basal skull fractures because of the direct trauma to the pituitary, with cranial nerve involvement, craniofacial trauma, and post-cardiopulmonary arrest. So if somebody had an arrest and they were brought back, you need to be concerned about the potential for antidiuretic hormone deficiencies. Most occasions, however, that diabetes insipidus is transient, but you can have persistent diabetes insipidus with an incidence of about 7% among TBI victims. There is also a syndrome of inappropriate antidiuretic hormone production, which is the most common TBI neuroendocrinopathy that causes a low sodium. During the acute phase, the severe DI is 2.9%. The incidence of less severe forms can be as much as 25%. And you've noticed that there's several times I've talked about fatigue. Well, pituitary dysfunction and fatigue are very common. They looked at one study of 64 individuals with at least a year post-TBI, and they underwent testing that included thyroid, adrenal, and the sex hormones, as well as growth hormones, and at least one pituitary axis, at least one of these hormones was abnormal in 90% of the participants. Well, we've also got issues with low testosterone. As much as 80% of men with severe TBI have low testosterone levels, or which is called hypogonadism. And normal or elevated levels of luteinizing hormone earlier in the hospitalization were significantly associated with a higher morbidity and mortality. So if their LH levels were high, then that meant that they were likely not to do well. That low testosterone on admission was associated with longer lengths of stay, lower average admission functional independent measurement scores, less improvement in that FIM score, and a lower FIM efficacy. And so they felt that testosterone levels doing testosterone levels may be important in the recovery of patients with traumatic brain injury. And so if the levels are low, supplementation may be important. And for women, the same thing is true. Estrogens, about 1/3 of female patients with head injuries experience temporary amenorrhea, which is a lack of menstrual periods. But that was usually for no longer than 3 months. And it didn't have the same morbidity and mortality effects that the low testosterone did. We can also see hyperglycemia, which is an elevated blood sugar. Among the 148 patients in this 4-year study of 626, 148 were admitted with hyperglycemia, and nearly 80% were diagnosed with stress-induced hyperglycemia. and 32% were diagnosed with diabetic hyperglycemia. So it's a stress-induced elevated in blood sugar. And the patients who had the stress-induced hyperglycemia had a 50% increased mortality compared to the non-diabetic hyperglycemia patients. And the diabetic hyperglycemia patients didn't have any significant increase in mortality. So if this is stress-induced, it's a very bad sign and needs to be treated aggressively. These symptoms include headaches, trouble concentrating, blurred vision, fatigue, weakness, and confusion. We're also seeing low vitamin D3 here in Alaska, especially. But it's common in patients after TBI and has an impaired cognitive function and more severe depressive symptoms. So almost 50% of patients after TBI had vitamin D deficiency, and 80% had insufficiency deficiency, which means it's not quite a deficiency, but it's pretty close. These symptoms include frequent illnesses, fatigue, bone and back pain because of absorption of calcium from the bones, or compression fractures because of osteoporosis, impaired wound healing, bone loss or osteoporosis, hair loss, interesting enough, and muscle pains. And then we've been looking at some new kinds of tests. Normally, patients with suspected head injuries are examined and evaluated by a doctor using a neurologic scale, and that's followed by a CT to detect the brain tissues. But there has been however, there's been a Banyan brain trauma indicator protein, which measures the levels of these two proteins in the blood, which are released from the brain into the blood after a head injury and can be detected within 12 hours of the injury. And that blood test could potentially prevent the unnecessary CTs and the radiation exposure to those patients, because it detects proteins that can predict which patients are likely to have an intracranial lesion that would have been apparent on CT and those that weren't. So those patients who have normal levels probably don't have anything that would show up on a CT and therefore don't need to be exposed to the CT. And so you can see where there are, on this picture, you've got this neuropeptide release, substance P, serotonin and vasodilation, and it's the trauma to these tissues that releases the protein. So to wrap it all up, what do we need to test? Well, we do need to test blood sugar. They may be diabetic, but they may have stress-induced hyperglycemia, and that stress-induced hyperglycemia leads to bad outcomes. And we need to look at the pituitary function. So you need to do a thyroid panel looking at the thyroid stimulating hormone, T4 and T3. So T4 is made by the pituitary and then goes to the tissues, where it's broken down to T3, which is actually the active form. We need to look at the antidiuretic hormone and make sure that there are not concerns with diabetes insipidus, so it can lead to dehydration. Look at growth hormone, and that's going to lead to problems in wound healing and depression and fatigue. The cortisol level should be its highest in the morning, and so doing an AM cortisol will give the best indication of how well the adrenal glands are working. And if there's not a good adrenal response, if there's a low cortisol level, then that makes you concerned that the adrenal corticotropic hormone is not working. And then you can look at testosterone and luteinizing hormone in men, or estrogen and follicle stimulating hormone in women. And the evidence is pretty clear that giving testosterone to men with TBIs who have low testosterone can improve function. You want to look at vitamin D, but specifically D3. So the kidney makes vitamin D2, and that goes to the skin where it is activated to the active form D3. And what don't we get a lot of in Alaska in the wintertime? Sunshine. So D3 is now recognized to be a very important part, and that regular vitamin D is not adequate. And then maybe we should be looking at these brain proteins. So I hope I've given you some interesting food for thought. And a recognition that it may not be all in the brain. There may be hormonal issues involved. And so your patient who's having fatigue, your patient who's having cognitive dysfunction, out of proportion to, especially out of proportion to the brain injury itself, those TBI patients who are having problems with appetite and weight gain or weight loss, depression and anxiety that is not responding to medication. Those are all patients who probably deserve some testing. And maybe this testing should be routine. Maybe by picking this up early, we can prevent the long-term consequences. By giving patients the hormones that they're missing, we can put them back into balance. Just like giving someone insulin who's a diabetic puts their blood sugar back in balance. And these brain proteins are very exciting in that they may be able to provide our patients with a screening tool that doesn't require radiation. So thank you very much for your attention. You may reach me at drtrescot@gmail.com. I'm happy to take any of your written questions. And if technology will help us, we'll try and do some questions by phone. Thank you very much.